Okay, so this is a class on some high yield questions, super quick. So the first question that we're going to discuss is what abnormality is the distinguishing feature of Kallmann syndrome? Super quick, like warm-up question. I think a lot of you guys got this right. It is um the low GnRH leading to low FSH and LH. Now, I just want to go over the other options super quick so you guys get an overview of everything. Low estrogen and progesterone due to dysfunctional ovaries is seen in Turner syndrome. And this one I kind of just put in there just to see if this would confuse you guys. Hypogonadotrophy is seen in Kallmann syndrome as well, but this is not, and so is like other features, but this is not like the distinguishing feature. So sometimes you can put in something in your exam that kind of looks like, oh yeah, this makes a lot of sense. Like I know Kallmann syndrome says hypogonadotrophy, but so most of the times it actually, I mean, even if it makes sense and it's not making like 100% sense, it can be the wrong um option. So don't get confused there. And low sperm count and fertility due to thyroid hormone abnormality. So another thing that like, you're like, oh yeah, sure, this makes sense. Like low fertility is seen in hypothyroidism, but it's not Kallmann syndrome. Okay, so things make sense, but it's not the right answer. This is again a warm-up question. Which of the following is not seen in FOOSH? So all of these are seen in FOOSH. So remember what FOOSH is. I'm gonna try and like maybe quickly draw it. It is fall on outstretched hand. So this is my guy. He's falling like this. Um, so what he's gonna hurt is his scaphoid. This is his hand over here that I tried to draw. It's gonna um the scaphoid, which is in the hand, it's one of the bones in the hand. Then Colles fracture, which is that very classic dinner fork deformity, is seen in Foosh. You can also see a ulnar styloid fracture and a supracondylar humerus fracture. The reason I put all of these is because it's important to ask, especially in like a scenario like NAC, you have to ask if you've oh, so if somebody comes up with Foosh and he only says this, you have to ask everything else too to get all the marks. So don't miss out on asking any of these. In an MCCQE scenario, it can be like, oh, patient comes in with this fracture. What else can be seen? So the correct answer over here, what is not seen is anterior shoulder dislocation. It's going to be posterior. Just because that's the reason I kind of drew this. If he's falling like this, obviously the force is going to be this way. So his shoulder is going to be dislocated there. I think most of you guys got this right. It is anterior shoulder dislocation. Okay. Now those are the easy ones. I think that's the last of the easy ones. Um, this one was a little bit more challenging, according to me. So you have completed 2 minutes of CPR. ECG monitor displays this. I think somebody did ask what kind of ECG this is. And I want to draw your attention to this part of the question, which says the patient has no pulse. So what does that mean? It means that when you remember the flowchart that I did on cardiac emergencies, you have to go this way where it says PEA. So pulseless electrical activity. So I remember when somebody on the group said, "Oh, what do I need to do for the heart block?" I said, the heart block is not your main concern. If your patient is pulseless, that is your main concern. That is the thing you need to fix first. Okay. So, like I said, PEA can sometimes be your best friend because unless it's VFib or pulsus V tachycardia, which are the two shockable rhythms, you have to do you have to fix the pulselessness first. And how do you do that? Is you have to push epi. If it's not a shockable rhythm, if it is, you just shock the patient and then push epi, right? But to fix the pulse, you have to do epi first. All of these are incorrect. This is not a shockable rhythm, so this would go. If, for example, if this was VTAC, then this would be the right answer. Okay. Um, yeah. And if you guys remember, if this is a shockable rhythm and defibrillation doesn't work and neither does epinephrine, you've pushed epinephrine every 3 to 5 minutes, you've done 3 shocks and it still doesn't work, then you can choose to give amiodarone or lidocaine. Okay. So just super quick recap on that. This was breathless electrical activity. You have to push epinephrine first. Sometimes they can even ask you, like, EMS is on their way, they've already pushed epinephrine, they're continuing CPR, what do you do? Do you shock it? No, you don't. Unless it's a shockable rhythm, you cannot shock it. Just remember, don't go shocking all types of rhythm because we're gonna ask you that. Oops. Okay, guys, guess you guys already saw that. But synchronized cardioversion is indicated in which of the following? It is atrial fibrillation. And we're going to discuss every single one of these and why you cannot shock these rhythms, right? I think there was a question on digitalis toxicity as well that we'll discuss a little bit about digitalis toxicity because it is very, 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 very important. And they can ask you a question, even in your NAC, they can be a patient that comes in with digitalis toxicity, and you guys need to know that. Um, so let's just go to you have an explanation page next. So, um, talking about synchronized cardioversion and where you can do it. Remember what I said about cardioversion in my cardiac emergencies class. Why would you cardiovert anyone, right? And what does cardioversion do? So if this is your normal EKG, right? What the cardioversion is focusing on is the peaks, and it's trying to make it regular, right? Cardioversion, remember, it's not, you have to remember this, the difference between cardioversion and defibrillation is that defibrillation, you take your 2 pads out, you shock the patient, you charge up to, like, say 200 joules, and you shock the patient. Cardioversion is just, you have to, if this is your patient, you have 2 pads, one on the chest, one on the side over here, and it's, you don't have to really charge it or anything like that. You don't have to, like, do anything major. It's not that serious. You just have to, and you're focusing on the peaks, and you can only do this for um um an arrhythmia which is called organized re-entrant arrhythmias, and I want to talk about why that's so. And again, over here you have some examples of re-entrant arrhythmias. And why is it that you can only do it in organized re-entrant arrhythmias? Every single word over here that I've written is important. If it's disorganized, for example, if it's like a complete heart block, like I think I put it here, yes, complete heart block. It's not organized, so that excludes it, right? Digitalis toxicity is another question that I will come upon in this video. um, Digitalis actually makes the heart more irritable to arrhythmias, and if you do synchronized cardioversion, you're probably gonna deteriorate the patient even more. Atrial fibrillation, on the other hand, that's shockable, right? I mean, that's something you can cardiovert because it fits all of these criteria over here. It is an organized re-entrant arrhythmia. So what happens in atrial fibrillation, atrial flutter, AV, NRT is that there's something wrong with the node, and it sends out signals that is a re-entrant signal, and which is why cardioversion can fix that. So it focuses on the peaks and it fixes it, right? So it's a really brief overview of why you can do that. And it makes sense, right? If you guys just remember that you can only cardiovert or organize re-entrant arrhythmias, you won't ever get confused, because what you want to do is, because of this faulty pathway that your node is doing in these 4 cases, you basically want to interrupt that with the shock delivered, with the current that is delivered by cardioversion, and make it normal again. And how you do that is that you focus on these peaks and you make them normal again, which is what I've written here. They're caused by circular abnormal electrical pathway, and you interrupt that circuit and you restore normal sinus rhythm. Everything else in that question is not um, uh, an organized reentrant current, and neither is multifocal atrial tachycardia. I want to talk about this later in a second, what it is. It's pretty rare, but it can confuse you, so it's better just to know what it is so it doesn't. It is, you just have to remember, like, what does it mean to be multifocal? So like I said in the previous ones, it's your SA node or there's some electrical pathway that's causing a circular irregular rhythm, right? In multifocal, it's not like that. It's not just one point that's causing the the abnormality. It's more than one. So if this is your heart, this is just it's going to be different points in the heart that's causing different electrical activities, and it's not going to be a circuit, it's not going to be regular, it's not going to be something that you can just put a shock into and then cause like the heart rate to be normal again or the rhythm to be normal, because it's disorganized and there are multiple ectopic atrial foci. You can't really do anything with just cardioverting it. I hope that's clear to you guys. Like, what you just need to know why you would cardiovert somebody. And if you just know the concept that you're trying to focus on the peaks over here, you're trying to interrupt a circular pathway, and you can only do it for organized reentrant arrhythmias. If you just keep these three things in mind, you'll know that um, you can't, it won't work on this one, right? And I have an EKG of multifocal atrial tachycardia. It's not that common, but nevertheless, I do have an EKG on that. But it'll be like it's characterized by three or more different P wave morphologies. So your P wave is going to be once like this, maybe once like this, once like this, because it's not organized at all. There's no logic to why this is happening. And the reason that is because there are multiple ectopic foci that are causing the P wave to happen. And if you guys remember, it's atrial, so that's why it's different P wave morphologies. Okay. And this will obviously cause varying PR intervals because the P wave is completely disorganized, and it's seen in sick and elderly patients. So you can very easily get a question that Mr. Brown is a 80-year-old patient. So let's say he has COPD. His potassium might be high, and they give you an EKG where your P waves are completely disorganized. What do you do? And if cardioversion is one of those options, that's going to be wrong. And because, like, again, hammering on that same point, it's not driven by a single abnormal circuit. And if it's not driven by a single abnormal circuit, that means cardioverting it will do nothing. Okay, it's like having multiple pacemakers. All of these ectopic foci are pacemakers and they're not working in cohesion. Okay, so I hope that makes sense why you wouldn't, cardiovert either of these guys. This I'm going to talk about in my next question right here. And maybe we'll do questions right at the end. Okay, that's okay with you guys. So again, this is just like a summary slide. Why cardioversion doesn't work in that is there's no single focus, no single circuit, no single abnormal circuit that you can just interrupt. It's just overall atrial irritability. And the reason I wanted to tie multifocal atrial tachycardia in with digitalis toxicity is because digitalis toxicity also causes myocardial irritability. And we're going to talk about this later. Before we do, and because it causes irritability, even in digitalis toxicity, cardioverting these patients actually causes further destabilization. And if you think about it, it makes sense too, right? If you have a myocardium that's anyways irritated by, these ectopic foci, and then you're introducing another circuit into it by cardioverting it, you're only gonna basically introduce another foci, right? Because they're not working in cohesion. You're not interrupting anything. You're just making the problem even worse. Okay. So how do you actually do it? How do you actually manage? you treat the underlying cause, like whatever, like Mr. Brown had increased potassium, for example, or decreased potassium, or whatever it is. You try and solve that problem, solve the hypoxia. These patients, for the most part, they're going to be um, palliative care. So depending on what your problem looks like, you try and solve that underlying problem, and you just give rate control like drugs. So you don't give antiarrhythmics because they're not effective. So try and do rate control, try and treat the underlying cause, and it's probably going to be somebody who, it won't like, it'll be like palliative care patient. It's probably end of life care and stuff like that, because it is seen in very old and complicated patients. But if you do get a question on this, and cardioversion or defibrillation or anything else is an option, you know that's wrong, and now you know why as well, right? Yeah. So this, as promised, is your EKG for multifocal atrial tachycardia. You can see the P waves are all different, and the PR intervals are all different too. I wanted to put in a quick atrial fibrillation versus atrial flutter EKG too. And you can see like this sort of pattern over here, which is called the sawtooth pattern for the atrial flutter. And now you guys know what to do, right? Now you guys know that cardioversion will work for these two guys, or it won't work for this guy. Yeah. Any questions right now at this point? I think we're at the last few slides, I believe. I just wanted to make sure that that's clear to everybody. Okay, I think there are no questions here. So the next question, and I believe this is the last one, is which of the following is contraindicated in the treatment of digitalis? So this is this was a very interesting thing for me to see, because the actual thing is it was this answer, but it was one it so 19% of you guys chose this as the answer. 31% said it was quinidine, which I'm unsure why that happened, which is why I want, maybe if one of you guys chose quinidine, you can tell me. 6% chose propranolol, phenytoin, 19%, and potassium chloride, 25% said that it's contraindicated. So the right answer is synchronized DC shock is contraindicated in digitalis-induced tachyarrhythmias. Okay. So it was interesting because I think this was the only question where people actually did not choose the right, like the majority vote wasn't correct. But otherwise, you guys did really well. And I don't know where this is coming from, but I don't know. You guys can, if you guys have any doubts on that, you can tell me. The reason why it's contraindicated in digitalis-induced tachyarrhythmias is, go to the next slide. I have an EKG for you. So what digitalis-induced tachycardia causes is the reverse tick mark EKG, which I've kind of like done the background here. So this is that reverse tick mark EKG, which causes a J depression. So let's go through this wordy slide together, and let's see why you can't do synchronized DC current. Is because like I told you before, that if you shock an already irritated myocardium, you're going to make the problem worse. Okay. And it can even trigger ventricular fibrillation. So digitalis increases myocardial sensitivity to electrical stimuli. So a lot of the times you'll have a patient who's on digitalis, and maybe you'll have like, he'll be on something else, and that might actually cause him to worsen. So you have to be very careful in these things. I also want to touch upon what like a NAC scenario in this case. if possible, and then we can take questions if you guys have any. Okay. So digitalis increases the vagal tone. It alters electrolyte balance and sensitizes the myocardium to arrhythmias. So what you might see in, for example, a NAC scenario is that a patient comes in, he has tachycardia, like he might not even tell you anything. He might just be like, oh yeah, I'm feeling really sick. And then you see his drugs and maybe digitalis is on them. You see his EKG, it'll be a tachyarrhythmia. And maybe, outside on the door, it'll be like, yeah, his heart rate is through the roof, right? So, and if you don't think about digitalis and you don't ask him about the drugs he's on, you're going to miss it. So you have to make sure you catch it. And for example, in this patient, in your next scenario, if you say, yeah, I'm going to cardiovert this patient, that is going to probably cause you to fail that station. So it's very important to know what to do, right? And again, like if you ask for his labs in this patient, what you're probably going to see is hypokalemia. Okay. And so treatment would be to fix all of that. Obviously, remember to say in your, especially I see this a lot like happening in the NAC that people just forget to say, stop doing the thing that's actually causing it. Like, for example, I just did a mock on like COPD, and the patient was a chronic smoker, and the person forgot to say, "Hey, maybe you should like stop smoking." So remember to say that if you especially if you're attempting something like the NAC, don't lose out on things that are obvious, right? Discontinue digitalis, correct the electrolyte imbalances, especially potassium, magnesium, and then if you want that extra edge, you can say you can administer digibind in severe cases, but your patient is probably going to be severe because it's causing EKG changes and he's probably going to be a little bit unstable. And if the patient is in arrhythmia, it could be simple tachycardia too. Like digitalis can also cause just simple tachycardia without it being an arrhythmia. If he does have so you have to do it according to what your patient says, right? It's not going to be, every patient's not going to be the same. Sometimes it can even be a bradyarrhythmia. So you can like do atropine because let's say your patient, because his myocardium is so irritated, it causes a bradyarrhythmia. It's very, very rare. But just remember, you treat the underlying cause and don't um, cardiovert for no reason, right? If it's a ventricular arrhythmia, just use lidocaine, phenytoin. You can also use quinidine if you want. And yeah, just remember not to cardiovert this patient because it will make the patient worse. Okay, that is the end of our short Q&A session. Do you guys have any questions at all on anything, or do you think one of the options that you guys chose, I didn't explain enough why it wasn't that, or anything you guys want me to repeat, anything like that?